Let's give the rest of our committee like 2 more minutes to join us. All right, good morning, everyone, and welcome to our remote DUR board meetings. As a reminder for our meeting today, if you are dialing in via telephone, Google Hangouts has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. If you are using your laptop for audio and visual during the meeting, you can control the mute function on the Hangout. We kindly ask that only those who are speaking to the group unmute their device. DUR board members, please reserve the question until the end of presentation or may ask in the Google Hangout meeting chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or email medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after meeting to help us improve our process moving forward. Thank you, and I leave the rest to Dr. Cannon.
Good morning. Welcome to everybody. This is our holiday meeting, I guess, so happy holidays to everybody. Thanks, Nang, for giving us kind of the rules of order here. So I think we have a quorum, so we'll call this meeting to order. You should have all received a copy of the minutes. So ask if there's any questions or edits that need to be made. All right. If not, is there a motion to approve? Thanks, Kumar. A second?
Second.
Thanks. All in favor?
Aye.
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 Any opposed? Perfect. That passes, and we will move on. Brian Larson is not able to join us this morning, so Nang, I think you're going to give us an update on the P&T committee this morning.
Thank you. So the P&T committee met in November to discuss the combination product for the treatment of HIV. The committee had recommended to follow the U.S. Department of Health and Human Services guideline for the HIV treatment insurance, pregnancy, and adult to be the preferred products on the PDL. The committee also recommended to have a fixed dose combination product to be referred that have the less toxicity and can be used alternatively in patients who are at risk for osteoporosis, CKD, and allow the grandfathering for a patient who already have been stable on the non-referred product regimen. The committee will meet again in February next year.
Great. Thank you for that. So turn it over now to the University of Utah for us to talk about prophylaxis for hereditary angioedema.
Good morning. Can everyone hear me okay?
Yes.
Okay. Let me just get my slides up. All right. So good morning. Today I will be talking about 4 medications indicated for prophylaxis of hereditary angioedema attacks. To start, I just wanted to revisit some background information about hereditary angioedema, abbreviated HAE, as Dr. Huen mentioned last month. It's a rare disorder that's estimated to occur in up to 1 in 50,000 people. It is inherited in an autosomal dominant fashion, though up to 25% of patients, in those cases, a new mutation causes the disorder. HAE is characterized by recurrent and usually unpredictable attacks of prolonged subcutaneous or submucosal swelling, or angioedema, which is commonly referred to as attacks. The angioedema is not allergen-mediated and not responsive to epinephrine, antihistamines, or glucocorticoids. Onset of symptoms of the disorder is variable, but it's often during childhood. And there's variability in affected anatomical locations and frequency of attacks among people living with HAE. Laryngeal attacks are relatively rare, but if they do occur, it can be life-threatening. Attacks can be debilitating and painful. Most patients with HAE report significant disrupted daily life, reduced attainment of career goals, and overall reduced quality of life compared to the general population. In most cases, the angioedema is thought to be mediated by an excess of bradykinin. Most patients lack functional C1 inhibitor. In the kallikrein-kinin pathway, the lack of functional C1 inhibitor leads to unchecked production of the vasoactive peptide bradykinin, triggering the angioedema. There are 3 main recognized types of hereditary angioedema as shown on this slide. Both HAE type 1, the most common type, and HAE type 2 are types of HAE with C1 inhibitor deficiency, which is characterized by a lack of functional C1 inhibitor. Patients with HAE type 1 and type 2 both usually have low C4 levels. Diagnosis of HAE with C1 inhibitor deficiency can be made based on a history of recurrent angioedema without urticaria, coupled with positive findings on laboratory parameters. The third type of HAE, HAE with normal levels of C1 inhibitor, consists of multiple subtypes. The true prevalence is unknown, but it rarely occurs compared to HAE type 1 or 2. Unlike HAE type 1 or 2, patients with this HAE group have normal levels of function of C1 inhibitor and normal levels of C4. Less is understood about this disorder, though evidence suggests that some of these subtypes may also be mediated by bradykinin. The goal of HAE treatment is to normalize the patient's life as much as possible. General treatment modalities for patients with hereditary angioedema include acute on-demand medications to improve attack symptoms, short-term prophylaxis, and long-term prophylaxis. Acute medications are recommended for all patients with HAE, regardless of whether they are receiving prophylactic medications. Short-term prophylaxis should be considered before a known patient trigger for HAE attacks. This often includes things like medical or dental procedures that cause physical trauma, but it could also include things like psychological stressors or menstruation. Clinical practice guidelines lack defined criteria for which patients to treat with long-term prophylaxis. They encourage an individualized decision based on weighing patient-specific factors, such as the patient's frequency and severity of HAE attacks when they are receiving acute treatment only, historical attack severity, ease of access to emergency care, whether the patient can effectively administer the acute medications, and patient-reported quality of life. Concurrent use of medications that are known to trigger angioedema are recommended only if the benefits outweigh the risk. This includes ACE inhibitors and exogenous estrogens, also possibly DPP4 inhibitors and neprilysin inhibitors. All right, so here are the 4 disease-targeted medications for HAE prophylaxis included in the report. Cinryze and Haegarda are both human plasma-derived C1 esterase inhibitors, which replace the C1 inhibitor protein. Both of these medications are indicated as routine prophylaxis in HAE patients ages 6 or older and require reconstitution for use. Cinryze is for intravenous use, while Haegarda is for subcutaneous administration. Both are given twice weekly. For clarity, I'll use the brand name to refer to these products. The other two products, lanadelumab and berotralstat, decrease activity of plasma kallikrein, reducing unchecked formation of bradykinin. Lanadelumab is a fully human monoclonal antibody indicated for hereditary angioedema prophylaxis in people ages 12 or older. It is given subcutaneously starting at a frequency of every 2 weeks. Berotralstat is also indicated for HAE prophylaxis in people 12 years or older. It is the first oral prophylactic medication and should be taken daily with food. Dose adjustments for berotralstat are recommended for patients with moderate to severe hepatic impairment and cases of intolerable GI side effects, or if used concurrently with PGP or PCRP inhibitors. All of the medications, including the intravenous Cinryze, can be self or caregiver administered with appropriate training. The 2020 U.S. Hereditary Angioedema Association guideline provides separate recommendations for HAE with or without C1 inhibitor deficiency. This slide summarizes the recommendations for non-pregnant adults. For short-term prophylaxis in patients with HAE with C1 inhibitor deficiency, plasma-derived C1 inhibitor administered before the trigger is recommended. According to experts, the delayed onset of effect for subcutaneous formulations are not ideal for new starts as short-term prophylaxis. Alternatives to plasma-derived C1 inhibitor include anabolic androgens such as danazol, recombinant C1 inhibitor such as Ruconest, or if the other options are not available, fresh frozen plasma. There's a lack of data for short-term prophylaxis in patients with HAE with normal C1 inhibitor levels. The U.S. Hereditary Angioedema Association states that treatment can be approached like patients with HAE type 1 or 2. For long-term prophylaxis in patients with HAE type 1 or 2, the U.S. Hereditary Angioedema Association strongly recommends intravenous or subcutaneous plasma-derived C1 inhibitor or lanadelumab as first-line treatment options. Another guideline, the 2019 Canadian and International Guideline, prefers the subcutaneous Haegarda or lanadelumab as first-line. Second-line options include oral antifibrinolytics such as tranexamic acid or oral anabolic androgens such as danazol. These options are less preferred due to a poor long-term safety and tolerability profile for androgens and possibly inferior efficacy for antifibrinolytics. In patients with HAE with normal C1 inhibitor, the U.S. Hereditary Angioedema Association weekly recommends progestin-only medication or an antifibrinolytic as the initial treatment for long-term prophylaxis based on low-quality evidence. They also mention that if those treatments fail in exceptional circumstances, plasma-derived C1 inhibitor could be tried, or that lanadelumab might be considered based on its mechanism of action. Importantly, the reviewed guidelines did not address the use of the oral medication berotralstat, likely due to its FDA approval after creation of these guidelines. During pregnancy, the U.S. Hereditary Angioedema Association prefers C1 inhibitor for prophylactic treatment, and the guideline recommends a similar treatment approach as adults in children, with added consideration to the age of approval of the recommended therapies. They do not provide separate statements with regards to the types of HAE. Their preferred choice for long-term prophylaxis is plasma-derived C1 inhibitor, given the long record of efficacy and safety. But they also state that lanadelumab is approved for those ages 12 and older. All four medications have been studied in at least one pivotal randomized placebo-controlled trial. This slide summarizes some of that information from the main trials. Comparison among these studies is complicated by different enrollment criteria, different allowed background therapies, and different definitions and other factors. All of these trials enrolled patients with HAE with C1 inhibitor deficiency, that is HAE type 1 or 2, and allowed access to on-demand treatment of attacks during the trial. Enrollment criteria varied based as shown in row 3 of this table, and duration varied. all trials required a minimum attack frequency that was typically measured during a run-in period before trial enrollment. And this requirement was either roughly at least 1 attack per month or at least 2 attacks per month, depending on the trial. And all of the medications met their primary efficacy endpoint, demonstrating a significant reduction in the number of HAE attacks compared to placebo, as shown in row 5 of the table. Benefits on patient-reported quality of life were sometimes inconsistent, but the magnitude of changes from baseline suggests that each therapy may improve some aspect of patient-reported quality of life that's meaningful for some patients. In open-label extension studies, sustained efficacy was observed over the different respective durations of follow-up. For additional details about the studies, consult the report. This slide summarizes safety information from each product's prescribing information. Both C1 inhibitors are contraindicated in patients with a history of hypersensitivity reactions, and labeled warnings or precautions include a risk for hypersensitivity reactions, thromboembolic events, or possible infectious agent transmission. The true incidence of thromboembolic events with these products is not known. The presence of other factors that increase the risk of thromboembolism may increase this risk. Guidelines discouraged use of indwelling ports to ease IV administration of Cinryze due to this risk. A warning or precaution for lanadelumab is the risk for hypersensitivity reactions, and berotralstat warns of the risk for QT prolongation that's been observed at doses exceeding those recommended for daily use. Common adverse events observed in clinical trials include injection site reactions for the subcutaneous treatments. Most of these events were considered mild. Gastrointestinal side effects are commonly observed with berotralstat. In clinical trials, these events were mostly mild to moderate in severity. Other common events are listed on this slide. For berotralstat, there is the potential for drug-drug interactions through multiple mechanisms, and it's recommended to avoid concurrent use with PGP inducers, while dose adjustments are recommended to manage some of the other potential interactions. So there's a lack of head-to-head comparisons among these 4 products in the prophylactic trials, and guidelines did not address the use of the newest medication, berotralstat. Because pivotal clinical trials did not require trial and failure of another long-term prophylactic therapy to enter the trial, it seems that all 4 products, including berotralstat, are initial prophylactic options in patients with HAE type 1 or 2. Guidelines or experts support using shared decision-making between providers and HAE patients to select a long-term prophylactic medication. For example, with consideration to the patient's age, comorbid conditions, risk factors for adverse events, and preferences about the administration route or frequency. So, the DUR board may consider creating prior authorization for Cinryze, Haegarda, lanadelumab, and berotralstat for hereditary angioedema prophylaxis. Some considerations for PA criteria are listed starting on page 29 of the report, and I included a summary on the next 2 slides. The board may consider requiring that patients have a certain diagnosis to use these medications. One option would be attestation to a diagnosis of HAE type 1 or type 2, since these were the patients included in pivotal trials, and the US guideline recommends Cinryze, Haegarda, or lanadelumab as first-line options for long-term prophylaxis in this HAE population. If this is selected, I would consider also allowing use of these products among the rare patient with HAE with normal levels of C1 inhibitor on a case-by-case basis. Instead of requiring HAE type 1 or 2, an alternative option for the diagnosis is to allow use among any patient with HAE, regardless of C1 inhibitor deficiency. I suggested provider attestation to the diagnosis, given some limitations of requiring that providers submit documentation to support their diagnosis, but the board could decide to require additional information, as I mentioned on pages 29 to 30 of the report. The board may also consider requiring attestation that the patient will be using these medications as prophylaxis, and that the provider assess the need for and discontinued as appropriate concurrent medications that may trigger angioedema, like ACE inhibitors or exogenous estrogens. Finally, each product's use could be restricted as per its age of FDA approval. That is ages 6 or older for Cinryze and Haegarda, and 12 or older for lanadelumab or berotralstat. I also list additional considerations that could be incorporated into the potential criteria I already mentioned on the previous slide. These include requiring that these agents be prescribed by or in consultation with an HAE specialist, requiring that patients meet certain criteria for prophylaxis, such as a minimum attack frequency or severity, requiring that patients do not chronically use these therapies concurrently, quantity limits according to the maximum dosing recommendations, and finally, step therapy among the first-line options if it's for cost-saving purposes. If prescribing by specialists is required, I encourage a broad approach as there are multiple provider specialties that could include HAE specialists. If it is preferred that patients meet certain criteria for prophylaxis, I also recommend using broad criteria that considers both attack frequency and severity and allows for use of historical information. If concurrent use is restricted, it's important to ensure patients still have access to appropriate therapies for short-term prophylactic use. If step therapy is a preferred approach, note that some products may be more favorable based on patient-specific factors. So that's all I had for today. Thanks for listening, and please feel free to let me know if you have any questions.
Thank you, Lauren. Do we have any questions from the board for Lauren on what she's presented today? All right. Hearing none, maybe before we go into the discussion amongst ourselves, Nang, you had some utilization data to present on this,
Yes.
correct?
Yes. Thank you. So to the board, the pharmacy team has some utilization data and also prior authorization that regarded the hereditary angioedema. So this is the data that is pulled from both the fee-for-service and the ACO. So regarding the acute treatment we don't have much utilization for these for acute treatment for HAE. The most of them is lying with the Firazyr or the generic of icatibant. There is 89 claims for the last year from the periods of November of 2020 to the November of 2021. We have the total of 5 patients with the ACO is using that product. And we have 6 claims with the Ruconest and only 1 patient with that acute treatment. For the prophylaxis, we only have 1 patient who is using Takhzyro, and with only 5 claims. So that shows very minimal utilization for these medications for this really rare disease. By that, the pharmacy team recommended to use a rare disease medication prior authorization for this to manage this disease. And on this page is a rare disease medication, PA, that we are planning to use to manage the HAE therapy. So all of the HAE therapy will require prior authorization at the point of sale. The provider will be required to submit the PA. The criteria is the medication is prescribed by or in consultation with a physician who specialize in the disease treatment. And Dr. Heath will recommend it. This will be accommodate a broad specialized, include immunologists, endocrinologists, whoever that can treat the HAE. Documented diagnosis, we are looking for the HAE. The provider is encouraged to submit the genetic testing or showing the C1 and the C4 level. Include the latest treatment guideline or compendia treatment recommendation with the 2020 HAE guideline, or if the provider have any more literature showing with their request. The use must follow FDA approved labeling, including age, any box warning, monitoring for any side effect. If current treatment standard recommend other treatment modality or intervention prior to use of the requested drugs, document the use appropriate first line treatment or intervention. Among the 4 prophylaxis regimen. Look like the guideline doesn't have a strongly reference over any of those. So we are not really asking for any trial and failure of the other product over one of the others. We also allow the off-label or compendia use, if any of those applicable, for the HAE treatment. So for initial authorization, it will be you up to 6 months and re-auth up to 1 year.
All right, thanks, Noon. Anything else on that the committee should know?
That should be all.
All right. So currently, very limited in terms of the number of patients. One for prophylaxis, and it looked like about, what, 6 or 7 for acute treatment.
Correct.
What questions on the proposed PA criteria from the state? Lots of head shaking. And then we didn't have any public comment on this.
No, we don't, Eric.
Okay, great. Thank you. Well, with that, let's move on. And I think the pharmacy team's presenting on parathyroid hormone next. Is that correct?
Yes. Do we have a motion to?
Oh.
Motion to accept the
I'll
rare
second
drug.
that.
Sorry, guys. Sounds like we got a
Feedback
motion
on
and a
this.
second. I'm just moving us along.
Yeah, I can
all
second
in
that too.
favor?
Aye.
Aye.
All right, any opposed? Great, that motion passes. So, all right, now to the pharmacy team for parathyroid hormone.
Okay, good morning, everyone. Sorry I wasn't here last time to present this for you. So we made the corrections that were recommended. So just a reminder, this is for Evenity, Forteo, and Tymlos. Currently, we have 3 patients only on Forteo, so we don't have many patients on osteoporosis therapy. The majority are on alendronate, which I know is probably the most common drug prescribed for this. So some of the concerns around the criteria were, we just had before trial and failure of anti-resorptive therapy. And it was brought up that we want to be more specific because trial and failure of therapy isn't necessarily very clear. So we changed it to intolerance to anti-resorptive therapy and clarified it's for bisphosphonates and denosumab, so Prolia. For example, a common intolerance to alendronate for some people is acid reflux or gastrointestinal distress. Below that, an example of failure of therapy would be osteoporotic fracture while on anti-resorptive therapy. I also made sure to keep the previous osteoporotic fracture, whether on therapy or not, and then made sure that these criteria below here matched with guideline recommendations of essentially what is the US adjustment for the FRAX score. So patients that are high risk for fracture, even if they don't meet the other criteria. And then one final correction that we added was specifics on the box warning for Evenity because it was slightly different from the warnings for the other parathyroid hormones. It included increased risk of myocardial infarction, stroke, and cardiovascular death, saying that it shouldn't be initiated in patients who have had one of these events within a certain amount of time for therapy. What questions do y'all have on these criteria?
Not
It's
a
a
question.
pretty-
I
it's a-
just appreciate the clarification. I feel like it is much clearer in terms of the criteria.
Okay, good, perfect.
All right, pretty quiet group today. They're all thinking about what they're buying me for Christmas. All right, and if there are no comments, questions, sounds like time. Do we have a motion to approve?
Sorry, just one. Are we putting trade names or generics in the body of the document?
I mean, for the parathyroid hormones, we have the trade names. We have both at the top here, just for clarification. And then we put the generics in for anti-resorptive therapy because that was specifically requested.
Okay, just thank you.
Yeah, thank you.
And you're comfortable with that, Sharon?
Yeah, either way, I couldn't remember which was, just for consistency with what we're doing.
Okay.
It's my brain.
No, that's perfect. Thank you. All right. So now we'll call for a motion. Kumar's got it. We got a second.
Sharon, second.
Thanks, Sharon. All in favor?
Aye.
Aye.
Thank you. Any nays? All right. Thank you very much, Stephanie. With that, I think we will have a discussion on the 13th of January about lupus nephritis treatments. I don't see any other business that we need to take care of this morning. Is that correct, Noon?
That's correct.
Dr.
Perfect.
Siegfried has her hand raised. I don't know if she meant to.
I'm sorry.
It sounds like she didn't mean to. So with that, I think we have accomplished a record here. 30 minutes. Well, hopefully everybody has a wonderful holiday. Hopefully all of you get to take time off with family, friends, and others, and enjoy a little time away from what we do on a regular day. So hope you all have a happy day. Wishing you all happy holidays, and we will reconvene in January. Do I have a motion to adjourn? Neil?
So moved.
All right, guys. Thank you. We'll see you in January.
Happy holidays, everyone.
Thanks.
Thank you.
Bye.
Bye.
Be safe.
Here.
Okay.